New data quietly published online shows that bulk billing rates have stagnated.
9% of people delayed seeing a doctor last year because of money, with the average gap fee now almost $40.
$50. That's how much the average Sydney patient's paying to visit the GP.
It's under a huge amount of pressure, and it's only going to get worse.
Over 600 GP full-time equivalents short in 2024. That number explodes to 6,100 by 2048. Bulk billing collapsed from 88.5% to 77.5% under current government. Only 20.7% of clinics bulk bill for all standard consultations. Average out-of-pocket cost hit $43 per visit. Emergency departments buckle under unprecedented demand. 90% of patients spend over 18 hours waiting for admission beds, up from 11 hours just 5 years ago. Mental health services face 20.7% psychiatrist shortage by 2048. 70% of psychiatrists report burnout symptoms. Australia faces 70,707 nurse shortage by 2035. Rural areas suffer 3 times fewer doctors per capita than cities. Small towns record half the nurses metropolitan areas enjoy. Indigenous communities witness systematic healthcare abandonment. The system reaches breaking point across every metric. Number 10 exposes the capital city nobody discusses. Number 2 will shock you beyond belief. We investigate healthcare collapse while politicians promise reform. Data reveals catastrophic failure across all states. Your support helps us continue. Please join our community. Number 10. Canberra mental health crisis exposes federal failure. Canberra Hospital operates adult acute mental health ward with 0 permanent psychiatrists. 7 positions exist. All filled by temporary locums. 1 in 4 funded specialist positions across NSW and ACT remain unfilled. ACT recorded 1,715 homeless people in 2021 census. Many suffer untreated mental illness. Psychiatric services turn away patients daily. Emergency departments fill with mental health presentations. 73% of trainee psychiatrists reported burnout in 2024. 13% considered leaving within 3 years. The training pipeline collapses while demand surges. Politicians walk past overflowing emergency departments daily. Psychiatric wards operate without permanent staff while MPs debate funding. Youth wait months for assessment. Some attempt suicide while languishing on waitlists. Number 9. Gold Coast bulk billing evaporates despite tourism wealth. Gold Coast encompasses over 750,000 people generating billions annually, yet only 20.7% of clinics bulk bill all consultations. Average out-of-pocket costs reached $43 per visit. Young adults aged 18 to 34 visit GPs 62% less often due to rising costs. Government promised universal bulk billing under 2025 election campaign. Reality differs sharply. Medicare payment increases from $42.85 to expected $70 for appointments under 20 minutes. However, this applies only to clinics bulk billing all services. Nearly quarter of clinics struggle meeting requirements. Over 5,000 GPs left Australian workforce in past 5 years. 3 out of 10 remaining plan retiring within next 5 years. Training positions struggle attracting applicants. Medical students choose alternatives offering better conditions. Tourism creates seasonal surges straining inadequate services. Emergency departments overflow during peak months. Locals compete with tourists for limited appointments. Number 8. Brisbane hospital bed crisis forces 18-hour emergency waits. Brisbane hospitals recorded 90% of admitted emergency patients spending over 18 hours before reaching beds. This increased nearly 7 hours since 2018. Queensland recorded 9.1 million emergency presentations in 2024 to 2025. Admitted patients faced catastrophic delays moving from emergency to wards. Bed block drives impossible wait times. September 2025 quarter documented 1,151 patients stuck waiting for aged care or NDIS support, increase of 54% over previous year. Every occupied bed means next emergency arrival cannot receive timely care. 67% of patients received care within triage timeframes, representing 33% failure rate. Nurses work double shifts covering absent colleagues. Burnout accelerates. Staff resignation rates climb throughout 2024 and 2025. Hospitals hire agency nurses at premium rates. Ambulances queue outside emergency departments for hours. Paramedics cannot transfer patients because no beds exist. Mental health presentations particularly strain resources. Psychiatric patients languish for days awaiting specialist beds. Number 7. Perth mining wealth fails rural healthcare desert. Western Australia recorded 85% of psychiatrists concentrated in metropolitan Perth. Rural and remote areas contained only 1.8% despite higher suicide rates. Small rural towns suffer 3 times fewer doctors per capita than metropolitan areas. Nurses and allied health workers exist at half metropolitan ratios. Mining industry generates billions. These revenues fail translating into rural healthcare investment. Wilcannia Multipurpose Service technically provides 24-hour emergency care. However, patients presenting between 7 p.m. and 7 a.m. must call ahead. Staff decide whether to attend. Rural WA faces acute GP shortages. Towns wait 12 weeks for appointments. Chronic conditions deteriorate while patients queue. Female psychiatrists comprise 43% of workforce but dominate rural placements. Average hours worked declined from 0.88 full-time equivalent in 2024 to projected 0.83 by 2048. International medical graduates fill critical gaps. However, recent policy changes mean fewer overseas doctors choose Australia. Number 6. Adelaide aging population overwhelms understaffed system. South Australia recorded highest proportion of residents aged over 65 nationally. Adelaide hospitals struggle under relentless pressure. Acute care sector predicts shortage of 26,665 full-time equivalent nurses by 2035. Primary healthcare follows with 21,765 shortage. Aged care requires additional 17,551 nurses. Adelaide averages 43-year-old registered nurses. However, percentage in their 20s decreases from 19% in 2022 to projected 16% by 2035. GP shortages hit Adelaide particularly hard. Patients report 6-week waits for standard appointments. Elective surgery waitlists exploded. Patients wait years for hip replacements, cataract operations. Mental health services operate at capacity. Psychiatrist shortages mean 6-month waits for initial consultations. Rural South Australia fares catastrophically worse. Towns possess single practitioners serving thousands. When that GP takes leave, communities go without medical coverage. Number 5. Newcastle elective surgery waitlists reach 5 years. Newcastle region recorded 791,000 elective surgery admissions nationally in 2024 to 2025. However, 6% waited over 1 year. Priority cases faced 12 to 18-month delays. Hip and knee replacements require years of waiting. Elderly patients deteriorate significantly. Some become too frail for surgery after waiting. Cataract operations face 8 to 12-month waits. Vision deteriorates affecting independence. Elderly people stop driving, become isolated. Chronic pain patients languish for procedures offering relief. They consume opioids for years awaiting interventions. Addiction develops. The surgical workforce shortage drives waitlist growth. Experienced surgeons retire faster than training replaces them. Operating theater capacity limits surgery numbers. Hospitals lack adequate theaters, equipment, recovery beds. We track healthcare data while mainstream outlets report government announcements uncritically. If this helps you, please join our community. Your support keeps us investigating. Number 4. Sydney emergency departments become refugee camps. Sydney emergency departments witnessed rough sleeping surge 23% in early 2024. Hospitals transformed into homeless shelters. Emergency presentations reached 9.1 million across Australian public hospitals in 2024 to 2025. 67% of patients received care within triage timeframes, representing 33% failure rate. For patients subsequently admitted, 90% waited over 18 hours completing emergency visits. This increased nearly 6 hours from 2020 levels. Bed block drives catastrophic waits. NSW recorded 1,151 patients stuck awaiting aged care or NDIS support in September 2025 quarter. Mental health presentations particularly strain departments. Psychiatric patients wait days for specialist beds. Domestic violence victims present seeking safety. However, refuge beds vanish. Indigenous Australians present at vastly disproportionate rates. Systemic barriers prevent primary care access. Ambulances queue for hours outside major hospitals. Blacktown Hospital improved urgent patient treatment from 17.7% to 31.4% in single year. However, this still means 68.6% wait beyond guidelines. Number 3. Melbourne nurse exodus leaves wards dangerously understaffed. Victoria recorded 30,000 homeless in 2021 census, highest state total. Healthcare worker housing stress drives additional crisis. Nurses cannot afford living near hospitals. Melbourne rents surged 39% between March 2021 and December 2023. Median weekly rent climbed from $450 to over $570. Nursing wages stagnated. Graduate nurses earn approximately $65,000 annually. This cannot sustain Melbourne housing. Commutes extend to 2 hours each way. Fatigue compounds demanding work. Australia faces projected shortage of 70,707 full-time equivalent nurses by 2035. Acute care sector requires additional 26,665. Primary healthcare needs 21,765. Aged care demands 17,551. Average nurse age sits at 43 years. However, percentage in 20s decreases from 19% in 2022 to projected 16% by 2035. Nursing education faces capacity constraints. Universities cannot expand placements without clinical sites. Hospitals lack staff supervising students. International nurse recruitment accelerated throughout 2024 and 2025. However, overseas nurses face registration delays, accommodation challenges. Many arrive then depart rapidly. Melbourne hospitals increasingly rely on agency nurses filling permanent positions. These temporary workers cost double or triple standard wages. Ward closures accelerated across Melbourne throughout 2025. Hospitals shut entire wards because insufficient nurses exist staffing them. Number 2. Rural Australia becomes healthcare void as doctors flee. Small rural towns recorded 3 times fewer doctors per capita than metropolitan areas. Nurses and allied health workers exist at half-city ratios. Remote communities face healthcare deserts where services approach zero. 21 healthcare occupations listed exclusively in shortage across regional Australia. However, urban centres show adequate or surplus practitioners same specialties. The maldistribution defines structural inequality. Outer regional New South Wales and South Australia possess lowest psychiatrist numbers nationally. Some areas record 1.4 psychiatrists per 100,000 population compared to 15 per 100,000 in major cities. The gap proves unbridgeable through current approaches. Rural GPs work crushing hours covering enormous geographic areas. Single practitioners serve towns of thousands. They provide obstetrics, emergency care, chronic disease management, mental health, aged care simultaneously. Burnout becomes inevitable. When rural GP takes leave, entire communities go without medical coverage. Pregnant women travel hundreds of kilometers for prenatal care. Diabetics miss monitoring. Mental health patients crisis without support. The fragility terrifies residents. Small rural hospitals closed obstetric services throughout 2024 and 2025. Women now travel hours giving birth in regional centers. Complications during transit killed mothers and babies. Preventable tragedies multiply across remote Australia. Medicare subsidized services per 1,000 people increased slightly in rural areas over past decade. However, they remain far below city rates. Access barriers including distance, cost, availability mean rural residents receive less care despite higher disease burden. Indigenous Australians in rural and remote regions face compounded disadvantage. They experience higher rates of chronic disease, shorter life expectancy, worse health outcomes. Yet culturally appropriate services remain virtually absent. Systemic racism pervades health system. Small towns lose younger workers because families cannot access healthcare. Parents refuse raising children without pediatricians nearby. The workforce exodus compounds service loss. Towns enter death spirals, losing population, services, economic base simultaneously. Remote area nurses provide healthcare backbone across vast territories. However, they work isolated without specialist support. Complex presentations exceed their scope. Patients requiring specialist care must travel or go without. Many deteriorate before reaching appropriate treatment. Telehealth expanded dramatically during pandemic. However, internet connectivity remains unreliable across remote Australia. Power outages disrupt virtual consultations. Examinations impossible via video mean missed diagnoses. Technology cannot substitute physical presence. The federal government announced various rural health initiatives. Financial incentives, training programs, placement supports all launched with fanfare. However, money fails attracting adequate practitioners. Bonuses reach $70,000 for some Queensland positions. Vacancies persist regardless. Medical students from rural backgrounds show higher likelihood practicing rurally after graduation. However, total rural students remain low. Universities concentrate in cities. Rural kids face barriers accessing medical education. The pipeline produces overwhelmingly urban-oriented doctors. International medical graduates fill critical rural gaps. However, recent policy changes and competing destinations mean fewer overseas doctors choose Australia. The talent pipeline threatens complete collapse. Rural healthcare void represents Australia's greatest shame. Wealthy nation abandons citizens based on postcode. Remote communities deserve equivalent care urban populations receive. Current trajectories guarantee continued inequality. Number 1. National GP crisis leaves 10,000 shortfall by 2031. Australia recorded 39,449 GPs providing primary care through Medicare in 2023. This represents increase of 2,533 from 2018. However, growth remains insufficient meeting healthcare needs. The system strains under relentless pressure. Average full-time equivalent per GP declined from 0.79 in 2018 to 0.74 in 2023. Doctors work fewer hours while population and complexity grow. Total workforce hours increase marginally while demand explodes. The mathematics produce inevitable crisis. Government modeling projects shortfall exceeding 600 GP full-time equivalents in 2024. This escalates to over 6,100 by 2048. Every state and territory experiences undersupply. New South Wales faces shortage exceeding 2,300 equivalent positions. Victoria confronts gap around 2,500. GP training positions struggle attracting applicants. Medical students observe impossible workloads, inadequate remuneration, crushing administrative burdens, lawsuit threats, burnout epidemic. They choose specialist training offering better conditions. The pipeline collapses. Over 5,000 GPs left Australian workforce in past 5 years. 30% of remaining GPs plan retiring within next 5 years. The exodus accelerates while replacement rates lag catastrophically. Every departing GP leaves larger patient load for colleagues. Bulk billing collapsed nationally from 88.5% to 77.5% under current government. Only 20.7% of GP clinics bulk bill all standard consultations. Average out-of-pocket cost reached $43 per visit by early 2025. Young adults aged 18 to 34 report visiting GPs 62% less often due to rising costs. This increased from 57% in 2024. Cost barriers prevent early intervention. Conditions deteriorate before treatment. Emergency presentations spike because primary care became unaffordable. Medicare rebate freeze lasting nearly decade left practices impossibly behind cost curves. Government promises fixing bulk billing through increased payments from $42.85 to expected $70 for sub-20-minute consultation. However, this applies only clinics bulk billing all services. Nearly quarter of doctor clinics cannot meet bulk billing requirements even with increased Medicare payments according to Department of Health briefings. Practice costs soared beyond rebate growth. Rent, wages, insurance, equipment, utilities all climbed relentlessly. Poor booking availability compounds cost barriers. Patients wait weeks for appointments. Many give up trying. Chronic conditions go unmanaged. Mental health deteriorates. Preventable hospitalizations multiply. The system fails at every level. GP shortages hit rural areas catastrophically harder than cities. Remote towns record half or fewer doctors per capita than metropolitan areas. Some communities rely on single practitioner serving thousands across vast territories. Female doctors comprise increasing workforce share. However, they work lower average hours than male counterparts. This gender shift reduces total system capacity even as headcount grows. Average full-time equivalent continues declining. International medical graduates provided 26.3% of psychiatry workforce in 2024. However, this proportion projected declining to 18.3% by 2048. Reliance on overseas doctors decreases while domestic production lags. The gap widens unstoppably. Mental health integration into general practice increased GP workload complexity. Patients present with anxiety, depression, trauma requiring extended consultations. Medicare rebates inadequately compensate time and expertise required. GPs avoid mental health because economics punish it. Chronic disease prevalence exploded across aging population. Diabetes, heart disease, respiratory conditions, cancers all require ongoing GP management. Multiple comorbidities become standard. 15-minute appointments cannot address complexity adequately. Administrative burden crushed GP morale. Electronic medical records, government reporting, insurance paperwork, referral management consume hours daily. Doctors spend more time documenting than treating. Many cite paperwork as primary burnout driver. Lawsuit threats deter doctors from practicing. Medical indemnity insurance premiums reached punishing levels. Defensive medicine practices increase costs while decreasing efficiency. Fear of litigation shapes clinical decisions inappropriately. The GP crisis represents catastrophic failure of healthcare policy. Market forces cannot provide primary care for all. Profit maximization conflicts with universal access. Treating healthcare as commodity rather than right produce disaster. Politicians promise reforms while conditions deteriorate. Bulk billing pledges ring hollow when clinics cannot survive on Medicare rates. Workforce expansion plans ignore decade-long training pipelines. Current trajectories guarantee worsening crisis. Behind every statistic sits family unable accessing basic healthcare. Parents watch children suffer waiting GP appointments. Elderly people ration medications because cannot afford doctor visits confirming prescriptions. Chronic disease patients deteriorate without management. We document healthcare collapse while government announces inadequate responses. The gap between political rhetoric and clinical reality grows unbridgeable. If you found this valuable, please join our community. Your support helps us continue.